Hi, everybody. My name is Shanelle Van Dyke with Quality Reporting Services. I will be providing you with a Medicare Beneficiary Quality Improvement Project, also known as MBQIP Overview. So just quickly, what we're going to cover is just an overview of the FLEX program, MBQIP purpose and benefits, as well as the goals of MBQIP. I'll be going over the measures, the quality reporting channels, and how they're all connected. I'll share with you a slide of the data submission deadline. I'll discuss the importance of reporting zero, which is also referred to as population and sampling. I'll just briefly touch on the additional voluntary MBQIP measures and quickly talk to you about hospital compare and public reporting. And then we'll wrap up with the advantages of participating in MBQIP, how we can help, as well as sharing some helpful resources with you to get started. So the FLEX grant program actually focuses on 4 core areas: support for quality improvement in critical access hospitals, support for operational and financial improvement in critical access hospitals, support for health system development and community engagement, which also includes integrating EMS and regional and local systems of care, and then also critical access hospital designation in your state. But for the purpose of today, we're just simply going to focus on item number 1, support for quality improvement in critical access hospitals. The Medicare Beneficiary Quality Improvement Project is a quality improvement activity under the Medicare Rural Hospital Flexibility Grant, also referred to as FLEX. It's a program of the Health Resources and Services Administration's Federal Office of Rural Health Policy, also known as ORF. The goal of MBQIP is to improve the quality of care provided in critical access hospitals by increasing quality data reporting in critical access hospitals and then driving quality improvement activities based on the data. This project provides an opportunity for individual hospitals to look at their own data, measure their outcomes against other critical access hospitals, and partner with other hospitals in the state around quality improvement initiatives to improve outcomes and provide the highest quality of care to each and every one of the patients that you serve within your community. So this project puts patients first by focusing on the health services, processes, and administration that's being provided by critical access hospitals. The goal will be to be achieved by asking you, the critical access hospitals, to report a specific set of relative measures that are relevant to critical access hospital setting in quality improvement projects to benefit patient care. The data will be aggregated into a national outcome for CAHs and shared with your state FLEX coordinator. This initiative takes a proactive approach to ensure critical access hospitals are well prepared to meet future quality reporting requirements. The primary objective of this project is for critical access hospitals to implement QI initiatives to improve their patient care and operations. MBQIP uses FLEX funding to support critical access hospitals with technical assistance and national benchmarks to improve healthcare outcomes, as well as quality improvement activities. And the state FLEX coordinator for Wyoming is Kyle Cameron. So, as I mentioned on the previous screen, some of the goals of MBQIP are for critical access hospitals to report a common set of role-relevant measures, and then use those measures and demonstrate improvement. And then it'll help prepare CHs for future reporting requirements from CMS and the feds, such as just an examples of value-based reimbursement would be hospital value-based purchasing, which currently only impacts acute care hospitals, but everybody's been hearing for quite some time that it could eventually become a requirement in the critical access hospital setting as well. So we will be doing quality measurement, quality improvement for improved patient outcomes. So here on your screen right now, you should see the MBQIP core measures. Going from left to right, I will be focusing on each of the domains. So the first column is titled Patient Safety. That's the patient safety domain, and it consists of 2 measures. It's the OP27 influenza vaccination measure, and then there's the inpatient immunization 2 influenza immunization measure. And later on in the presentation, I'm actually going to show you how each one of these measures or measure sets is collected and where it's reported. For example, OP27 is actually an outpatient measure, but it's classified as a hospital or healthcare acquired infection measure, which means for the most part, typically your infection preventionist or infection control nurse collects and reports this data to the CDC via the NHSN website. As for the inpatient immunization 2 measure, that is typically collected and reported in the CART application or by a third-party vendor. But for the purpose of this presentation, the majority of the Wyoming Critical Access Hospitals use the CART application, which stands for CMS Abstraction and Reporting Tool. Again, I will dive into this a little bit more later in the presentation. The second column is titled Patient Engagement. That domain consists solely of the Hospital Consumer Assessment of Healthcare Provider and Systems, also referred to HCAPS. The third column is the Care Transitions domain, which consists of the Emergency Department Transfer Communication. There are 7 categories or domains with a total of 27 data elements and or measures within each domain. And on the screen, you'll see that the 7 domains are actually provided. We also have a quick recording similar to this one that provides in-depth training and overview of the ED transfer communication, data collection, and reporting. The final and last column is the outpatient domain, and there are a total of 9 measures within that domain. They are all outpatient measures, and those are all collected and reported within the CART application and on the QualityNet website. And again, I'm going to get into each one of these domains and their measures and how they're collected and reported later on. So how does this all work? How is it all connected? So starting on the left-hand side of the screen and kind of going in like a circle, the CMS inpatient measures, which are submitted via the CART application or by a vendor, the only inpatient measure is the immunization 2 influenza vaccination. Then moving on to the CMS outpatient measures, those are submitted in CART or a vendor tool. And here on the screen, you will see I actually only have, I think it's 6, 7, 8 of the measures. There is one measure that's collected differently, and I'm going to touch on that here in a minute. But these ones right here, the CMS outpatient measures, those are all collected and reported in the CART tool or via a vendor tool. And then moving on to the next bubble, the CMS outpatient measures that are submitted through QualityNet Secure Portal is the OP22, that's the patient left without being seen. That is considered to be a structural measure, which is just a question that's answered annually. You log into the QualityNet website, you go to structural measures, you select OP22, it simply just asks for a numerator and denominator for patient left without being seen. These other measures, the CMS inpatient measure, the immunization 2, and the additional CMS outpatient measures that are collected via the CART tool, those are considered abstraction measures. So that is where your facility physically abstracts the information from the chart, enters it in CART, and then uploads it to the QNet website to be submitted to CMS. And then lastly, we have HCAPS, which typically is done by a vendor such as Press Ganey, Avatar, there's a whole bunch of them, or some facilities self-administer. I think it's kind of gone away from the self-administering and is solely being done by vendors because of all the very, very strict requirements that CMS has in place. A lot of the self-administration can't be done anymore unless you were grandfathered in. But HCAP's very similar. If your facility pays a vendor to do it, the vendor actually sends out the survey, collects the data, and actually uploads it to the QNet website for submission to CMS. So additional measures is the OP27, that is the healthcare personnel influenza vaccination. That is an outpatient healthcare associated infection measure that is collected in NHSN, which also gets to CMS. And then the ED transfer data collection and measures are done in the ED transfer data collection Excel tool. You generate a quarterly report, you email that to your your state flex coordinator, Kyle Cameron, and you can also email it to myself. And then in turn, Kyle gets the data off to the feds. So this slide and the previous slide covers all of the measures, how they're collected, and how they're reported. Essentially, whatever the venue is, whether it's the card application, whether it's the ED Transfer Excel database for the ED transfer measures, or NHSN for the HAI measure, or HCAPS, essentially they all end up getting to CMS by the system that you're using. So here real fast, like I'm just showing you screenshots, this slide right here gives screenshots of the CMS abstraction and reporting tool cart. This is where all of the inpatient and outpatient abstraction measures are collected. This would be installed on your computer at your facility. You would abstract the chart into this system, and then when it's time to submit it to CMS, you would do what we call export and upload, where you export the data via a secure zip file. You log into QNet, you upload that zip file. That's how it gets to the feds. The QualityNet Secure Portal. So this is for inpatient, outpatient data submission. This is the second part. This is where the data is uploaded for the feds. In addition, this is also where OP22, patient left without being seen, is entered. You log into QNet. Over here on the right-hand side of the screen, you would select the program, which for instance could be Outpatient Hospital Quality Reporting Program. You log in. That's where you upload your outpatient data, and or where you would simply click on structural measures, click on OP22, enter your numerator and denominator, and submit it. So the inpatient and outpatient abstraction measures are done quarterly and submitted quarterly, and the structural measure, OP22, is done annually. On the next slide here is a couple snapshots of the ED Transfer Communication Excel database. This is for the data collection and submission of the ED transfer data. You download this tool onto your computer, you abstract your data into it, and then every quarter you generate your report and you email it to your Wyoming State Flex Coordinator, Kyle Cameron. And we also request that if you wouldn't mind emailing it to myself as well. It's just a great double check for us to make sure that we're getting each report from each facility by the deadline. This last screen, again, this is going to be strictly geared towards your infection control nurse or infection preventionist. OP27, the outpatient HAI measure, which is again the healthcare influenza personnel vaccination. This is just a couple screenshots of the NHSN website where your infection preventionist logs in and actually submits all the HAI data. They might be also reporting CAUTI and CLABSI and so on and so forth. But for the purpose of MBQIP, the only measure that's required that's an HAI measure is OP27. So some upcoming MBQIP data submission deadlines. I have it broken down by domain or topic. So the ED transfer data, the next set, which is first quarter 2017, which is January through March data, is due April 30th. And then second quarter, April through June data, is due July 31st. Again, that's the report you email to myself and Kyle Cameron. The outpatient data, the abstracted data, is due May 1st for fourth quarter, which is October through December data, and August 1st, which is first quarter, January through March data. And then inpatient is closely after outpatient. So inpatient data is due May 15th for fourth quarter and August 15th for first quarter. And then population and sampling, the deadlines are identical to outpatient. And the population and sampling is how you report zero effectively, and that is for inpatient and outpatient. That's how you would submit your reporting of zero, which I'm going to dive into here in a minute. Okay, so reporting zero. Currently, there is no way for us to accurately identify whether a facility is actively participating if you do not have any eligible cases to report. So what that means is if in a given quarter, let's say you don't have any inpatient or let's say any outpatient data that is eligible for abstraction. The only way for us to know that you didn't have any cases to report versus the fact that you just didn't report whether you were out on vacation or sick or ran into technical issues and just didn't get your data submitted, the only way for us to know this is if you report your population and sampling. So population and sampling refers to the recorded number of cases that a hospital is submitting to the QualityNet website to CMS. And this is done directly through the QualityNet Secure Portal. The population and sampling application enables you to enter inpatient and outpatient population data of both your Medicare and non-Medicare patients that meet the inclusion criteria for each of the measure sets. So simply what you would do is log into QNet, you'd click on population and sampling, and it would bring, you'd say whatever quarter, and it would bring up a table, and it would say, let's say for first quarter, it would be a table January, February, and March, and it would break it out by Medicare and non-Medicare, and then by topic, so like chest pain, AMI, so on, and you would simply just enter in all zeros if you had nothing to report, and then you would click submit. And that's how we would know that you did not have any eligible cases to report versus simply not participating. And this is really important because as MBQIP reporting is tied to flex funding, if we don't know that you don't have any cases to report and we just see a bunch of NAs in the data we get back from the feds, then it just looks like you're not participating, which could put you at risk of maybe not getting funds. Whereas if we get the reports from the feds and we see that you have zeros, then we know that you're actively participating. Quickly, before I move on to this slide, I just want to mention that we also have a quick little tutorial presentation similar to this one that we're working on for population and sampling. It's just going to be probably like a quick 10-minute webinar recording that walks you through the steps of how to submit your population and sampling to report zero. This slide right now is the MBQIP additional measures. These are voluntary, so I'm not going to really touch on them for the most part. But as you can see, it just provides a snapshot. Kind of down at the bottom left-hand corner, you'll barely see the patient safety culture survey that's kind of cut off. This is actually one of the voluntary additional measures that the state of Wyoming, the critical access hospitals, you and your peers decided that you wanted to work on. So as you know, we are working on patient safety culture right now in the state of Wyoming. We are just about wrapping up in collecting the baseline and are going to have started to move forward with the quality improvement activities. The first one's going to take place at the end of March and will continue on throughout the rest of the Flex Grant year. And then finally, the 2017 to 2018 Flex Grant year, we're going to do remeasurement. Any of these additional measures are voluntary and you can totally collect and report them. There's no problem with that whatsoever. We actually encourage it. And actually, almost all the critical access hospitals are still collecting and reporting the pneumonia measures. That's done in CART. And then over on the right-hand side of the screen under outpatient, there are some additional outpatient measures like stroke and ED throughput. Those are also voluntary, and a majority of the critical access hospitals in Wyoming are collecting on those. Again, continuing on, there are some additional voluntary measures here. You've got stroke and VTE. Again, those are also collected and reported in CART, and there are quite a few of you who are doing that, which is awesome. Let me see here. Oh, there we go. MBQIP and Hospital Compare. So the goal of MBQIP is to get you guys, as I mentioned, to collect and report relevant measures to critical access hospitals, and then also improve on those measures, but also to be transparent and publicly report that data via Hospital Compared. So almost the majority of hospitals in the United States are publicly reporting their data on Hospital Compare because it's a nationwide effort. And it's all, the focus is on improving quality and becoming transparent, and it allows you to benchmark and compare yourself actually with, different facilities in different states, facilities within your same state, whether it's acute care or critical access, you name it. And the similarity between Hospital Compare and MBQIP is that MBQIP is also a nationwide effort. It's all critical access hospitals. Its focus is on improving quality of care, being transparent, publicly reporting your data, improving the data, benchmarking with peers, and so on and so forth. So hospital compare, how do you get out there? How do you make sure you're reporting your data? It's a few simple steps. Again, you log into QNet, you go under quality programs, you click on hospital quality reporting, you click on my tasks, and then you go to the box titled Manage Notice of Participation, and then click on View Edit Notice of Participation. And you want to make sure that everything for inpatient and outpatient is at public reporting. You want to make sure that it's not, that the quality improvement only is not selected. If you see that quality improvement only is selected, that means that you're registered as participating and reporting your data, but it's not being publicly reported to Hospital Compare. As part of the MBQIP requirement, you need to be publicly reporting your inpatient and outpatient data. Again, we are going to be providing another 7 or 10 minute webinar tutorial that will walk you through the steps of how to log onto QNet and edit and manage your notice of participation to make sure you're publicly reporting. So advantages of participating. Why is MBQIP important? With the passage of Meaningful Use and the Affordable Care Act, heightened national attention on quality activities and reporting is becoming more and more. In the environment of meaningful use, pay for performance, bundled payments, and accountable care organizations, critical access hospitals are increasingly likely to be compared with their urban counterparts to ensure public confidence in the quality of health services being provided. So this initiative takes a proactive and visionary approach to ensure CAHs are well equipped and prepared to meet future quality legislation, which we all know right now there's a lot of changes happening. Additionally, MBQIP fulfills the Flex Grant QI objectives regarding hospital compare reporting and supporting participation in various multi-hospital QI initiatives. The main emphasis of this project is putting patients first by focusing on improving healthcare services, processes, and administration. So to advance MBQIP, Flex funds are or may be used to support efforts around QI activities related to select role-relevant measures within the MBQIP program. Flex funds can also be used to provide technical assistance for hospitals in reporting all of these measures, both internally and also to Hospital Compare. One thing that we've been doing is working on QI initiatives in your state for these measures. We've been working on and sharing benchmarking amongst critical access hospitals across these measures. I have been providing technical assistance on each one of these tools, how to download it, how to navigate it, how to start reporting the data, and how to submit the data. There's just so much stuff going on right now that we've been creating and developing to better assist you guys. So I'm going to kind of wrap up the PowerPoint because some of these slides are starting to get redundant. But you have a great team in Wyoming to help you. You have myself, you have Rochelle Spinarski with QHI, and you also have Kyle Cameron, the Wyoming Flex Coordinator. These next couple of slides I'm just going to breeze through, but they're all links to give you helpful resources for outpatient and inpatient, such as a guide for how to work with your notice of participation, a guide to submit your population and sampling, how to report the web-based outpatient measures, CART basics, how to log in, download CART, get into CART, and start navigating it, how to start abstracting your cases in CART, both the inpatient-outpatient specifications manual, which are a guide to help you abstract the data out of your chart. And then there are some resources for ED transfer. There are some resources for HCAPs as well as NHs. But here on this last slide, you will see a contact information for myself, Kyle, and Rochelle. So with that being said, I'm going to stop the presentation. Feel free to reach out if you have additional questions, and have a great day. Thanks.